NTV.
Welcome back to the #1 breakfast show in the country, Morning at NTV, with me, Romeo Busik. We are getting into a very contentious conversation on HIV and AIDS. Did you know that over 1.4 million people are living with HIV and AIDS in Uganda? And out of that number, 1.2 million, 1.26 million people are actually on medicine. What about the, majority of them are men, the 250,000 missing men, 200 to 300,000. Where are they? I would like to know. We have Dr. Joshua. Yes, Dr. Joshua. He is actually the Assistant Commissioner AIDS Control Program right at the Ministry of Health. We would like to expound more on this conversation. Where are the men? And why is it that we are seeing more infections among the girls than the boys? 6.7% among the girls and around 4.7% among the boys. Why is that happening? Why are so many infections among adults and girls and so forth? A very good morning.
Good morning, Romeo.
Welcome.
Thank you very much.
So where are the men? I'll start with that.
Good morning, viewers, and I think I want to thank NTV for giving us an opportunity to speak to the country about the situation of HIV and AIDS in Uganda, where we are with respect to response, and some of the gaps that you are identifying. As you clearly indicate, we are now having an epidemic which is a mature epidemic in the country. We have an HIV prevalence of 6.2% in the adult population. It is much lower in the younger 0 to 14 years at 0.5%. Now, among the adults, the epidemic is predominantly affecting disproportionately women, as you indicate. We have 4.7% among the men and about 7.6% among the women, which is really a very big disparity. And when you try to break down by a number of socio-demographic and geographical distribution of the disease, we have really quite a heterogeneous epidemic. Among the young people, 15 to 24 years, which you are referring to, we have a prevalence of about 2.1%. Now, 2.1%...
That is 15 to 64?
15 to 24.
All right. 15
to 24. Now, among those, you find that the epidemic is fourfold times when you look at the boys compared to the women, the girls. 0.8% among the boys and 3.3% among the girls. That's quite a big disparity. And as you're indicating, we must make sure that as we roll out our interventions, we focus on the girl child and ensure that we promote their health. But as we promote their health, we also look at the factors that predispose them to those health outcomes. So
what are some of the factors that make it risky for the women to get infected with the HIV?
As you know, in our country here and in many of the sub-Saharan African countries, Romeo, we've had issues of the gender imbalances that sometimes have not favored our girl child. In many of the societies, the girl child have not been given opportunities for education. You find that they are left behind when there's a choice between a boy and a girl. Some of the families will choose.
Many of them are doing unpaid work, getting into marriages and so forth.
Yes, they may not prefer to send the girl. Many of the girls have, even when they've been sent to school, they have dropped out of school. Many of the girls are getting married off early in some of the cultures and some of the societies. And this is really quite a disturbing observation. And many of those, together with the issues of gender-based violence and the issues of, a lot of lack of socioeconomic empowerment of the girls, has really disfavored our girls and has put them at a higher vulnerability to HIV infection. And this is what we're seeing in our data. There are, of course, other biological factors. As we know, when the girls are still young and they engage in sexual activities, they get really they're not ready for that, and they may have a higher likelihood of getting infected compared to if they had a longer life without being exposed to sex and to potential HIV infection. So we need to look at it as in a holistic manner, right from the socio-economic side, but also looking at the health side. And ensure that we address at each of those stages the factors that create vulnerability and expose our young girls to HIV infection. But of course, as we do that, we also need to be cognizant that we shouldn't leave the boys behind. Some of the programs we have done have really not been also looking at the boys, and as a result, in some of the instances, we find that the attitudes of the boys and the men
play a big role.
Have played a big role in creating even further.
Are the boys engaging in developmental activities, or are they simply idle in that they'll be having more time to woo these young girls? Go ahead.
We want the young people to be in school. This country has been fortunate to have programs that are promoting universal primary education and universal secondary education.
I'm glad. I'm glad finally someone can see it from that perspective.
Yes.
Instead of blaming the boys and so forth, and also blaming the girls on their dress code and so forth, there was always that blame game. When the girl gets pregnant, there was always that blame game. What was she wearing? Where was she going at such a time? And blah, 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 blah. Yes. And for the boys, they'll be like, this and that was happening. The boy was not in school, so they would try to justify it. So we need those development programs. Keep a boy in school. Find them employment activities so that they do not focus on such unscrupulous activities. Go ahead, Dr.
There are data which actually show that, when the girls and even to that extent boys remain in school, the vulnerability comes down so significantly that for every extra year that the girls and the boys are in school, the prevalence of HIV and HIV incidents actually come down. So many of the programs we're implementing now, working with our development partners, the US government, the Global Fund and the government of Uganda, as well as the UN, we are focusing on adolescent girls and young women, and especially keeping them in school. There are things that we know that have contributed sometimes to girls dropping out of school. We want to address those issues of subsidies for school fees. Some of the children cannot afford school fees. Issues of menstrual hygiene. Those are issues that need to be focused on to make sure that the girls have access to safe and clean menstrual hygiene. So many of the programs we're doing now in our health sector, together with our partners, is to see how do we promote, first of all, the girls and boys enrolling in school, but also for those that are falling out of the cracks because of some of the issues of socioeconomic nature, to support them with subsidies, small grants, through their schools, through the Ministry of Education. We're working very closely with the Ministry of Education. We're working with the Ministry of Gender, Labour and Social Development to make sure that those programs in school are handled by Ministry of Education, but also for those girls that are out of school, are given a second chance for vocational training and other forms of engagement. The Ministry of Gender, Labour and Social Development, together with our civil society development partners, that they can support them to give them a second chance, so that they are not idle and vulnerable, so that we protect them from the risk factors for acquisition of HIV infection.
Dr. Joshua Musinguzi, there is a statement young people usually make, and it's usually hard for me to even cram. I can rehearse it several times, and I usually fail. I fear HIV more than I fear pregnancy, or is it the other way around? It doesn't make sense to me. You cannot fear pregnancy more than you fear HIV. It doesn't make any sense. Why are young people actually exercising such a chain of thought that they fear a pregnancy more than they do HIV, something that you're going to live with for the rest of your life? It doesn't make any sense.
It doesn't make much sense. So those are some of the myths around HIV and AIDS, and some of the, probably I would call, careless statements that were perhaps informed by wrong attitudes and wrong knowledge.
Because for me, it's the other way around.
Yes,
I fear HIV more.
It should be. We want to make sure that we don't want to get for them to get pregnant.
Indeed.
We don't want to expose them to HIV infection. We want them to be safe. We want them to go through school, get job opportunities, and raise families when they are ready at the right age and right time. So we want to, these kinds of attitudes and these kinds of knowledge gaps need to really be addressed.
But where does it come from?
Right from the family level, at the parenting level. I think there's an issue for a need for us to strengthen parenting in this country. There's a lot of absentee parenting, where the man and the lady and the wife are too busy trying to make careers, and they leave the children to other caretakers, sometimes the maids, sometimes other relatives, and in those circumstances the children will not get the right support that they need to grow up responsibly. So we really need to be able to address those issues. Of course, the next stage, of course, is when they get into school. At school, we must engage with the school so that they are given the right knowledge, the right attitudes, the right information, and keep them through the school cycle, so that when they become adults, they become responsible adults and understand that this life is not about just pleasure and going around, but being responsible as individuals, keep themselves healthy, keep themselves away from HIV infection, but also other diseases, because really it is not just single disease approaches that we are doing now in the Ministry of Health. We are talking about integration, so that we make sure that the person is safe from all health vulnerabilities, malaria and other diseases, so that the person grows into a full, healthy and responsible adult.
In the young people out there, there is no way you can say that you fear pregnancy more than you do HIV. When you get pregnant, there's a chance that you could give birth to the future president. That's for a fact. Yes, you could give birth to the future president. But if you grapple with HIV, you have this disease for the rest of your life. And if you get a chance to have a child at a later stage of your life, this child will not focus on becoming president. They will focus on being worried for you because you have HIV and AIDS. Yes, they will not concentrate in school. I'll be saying, my father, my mother is having HIV and AIDS. They're going to die anytime soon. So there will be no focus, because they do not know, like you, that HIV antiretroviral medicine will give you a lengthy life. They just know you're sick and anytime you're going to die. So psychologically, it actually perturbs the young child. We need to do more to work on such issues. You cannot fear pregnancy more than you do HIV. It doesn't make any sense. Dr. Joshua Musinguzi, let's continue. Share with us the role of hunger and poverty in worsening the effects of HIV and AIDS in those who are already affected.
Yeah, socioeconomic vulnerabilities, as we know, fuel for disease, not just HIV, AIDS, but for all other diseases. As you know, a person who cannot fend for themselves, they will not be able to make ends meet, and therefore they look around for options. And many times the options are not the right options. Some of them, people get into relationships that are not healthy relationships, and some of them, in the process of getting into those healthy relationships, they will engage in risky sexual behaviors, and those behaviors will lead them to HIV and AIDS. So we are having to respond in a holistic manner. And as you know, the Ugandan HIV response is a multi-sectoral response. Health is responsible for the public health aspects of the response, but we are working with our other partners in the government, the different ministries, the civil society organizations, to address different issues of the tenets of the epidemic, to look at the issues of socioeconomic nature, to look at the issues of health, and to look at all these other issues. On our side, we want to make sure that anybody that falls through these cracks and gets HIV exposed and infected, we provide them support. And this is support that is right from the beginning to the end, ensuring that we identify them through testing. Testing is an important entry point for our public health response. Those that are HIV infected, we link them to treatment. We now have drugs, as you know. The government and the development partners, the US government, the Global Fund, the UN, and the Ministry of Health have really worked out a strong logistic mechanism to ensure that we have testing equipment, we have drugs. In the past, you used to hear about drug stockouts. Now we no longer have that problem. So for both our adult and young population that are HIV exposed, that are identified as HIV infected, we are able to put them on treatment. And the goal of treatment is to make sure that we suppress viral load.
But there's a group you haven't reached out to, and those are partly the men. They're missing 250,000+ men. So
overall, our program, Romeo, has been extremely successful. We have, in this country now, hit the 2020 targets for 90. The first 90, which is the testing, we have been able to test 89%, and identify 89% of the people living with HIV in this country. And we have been able to put 89%, close to now 90% of those people on treatment, and 90% of them are virally suppressed. Now that's the overall metrics, which is quite good. I think Uganda has really led from the front in that aspect. Right from the time we updated our policies for test and treat to make sure that everybody who is HIV exposed is identified and put on treatment.
So as we vie to reach 95 target, why are men adamant to go and test and actually enroll on antiretroviral treatment?
So you've got it right there, Romeo. We have some gaps in the cascade, as I would like to just explain here. Now, whereas we have done very, very well overall, I've done very well among the women, we still have gaps especially among some subpopulation groups. And those are the men, as you have indicated. Among men, our cascade is slightly lower than among the women. We also have a gap among adolescents and children.
Let's first focus on the men. Why don't they show up?
Yes, I'll come on the men. I just wanted to make sure that we identify all the groups that are still lagging behind.
Okay.
So we have men, we have children, we also have adolescents, these young people. It's also very important to get the young people tested, linked to treatment, virally suppressed. We also have what we call key and priority populations. Some of these, sometimes for hidden populations. We have men who have sex with men, we have sex workers, we have fishing communities, we have people who inject drugs. We must make sure that all these people are reached. Because unless you reach everybody and leave no one behind, the epidemic is going to rebound. So we want to make sure they're all addressed. Now we're coming back to men. Men are difficult, as you know ourselves. These men are missing usually everywhere, as I was saying earlier.
You're telling me they are missing in church, they're missing in the mosques.
They are missing in the mosques. They are missing
simply because of their busy nature, looking for trying to eke a living.
They have excuses. They have excuses that they are trying to eke a living.
Yeah.
So you find many of them are saying, when I don't have time to come to the clinic to get tested and get linked to treatment, especially when they are healthier with our test and treat policy. Sometimes they say, I'm still okay. Why? What's the issue?
Yeah.
And also sometimes it is just sheer cowardice that they don't want to know their status. They're scared about their status. There are also other socioeconomic factors like ability to reach the places where testing and treatment and services can be provided. But we're working around the clock to make sure we get these men. This country has a number of partners that are really working very hard. We have regional partners across the country, and they're devising various mechanisms of reaching men. Many times now what we are doing is to find them where they are in their workplaces. If people are running borders, they are in their stages, or people are bricklaying, they are in those places, the virombes, where they do their bricks, and other places of work. We want to make sure we do outreach services that can reach them and identify them in their workplaces and link them to care. And many of our partners are doing that. We are also looking at modifying our approaches within the facilities. For example, in many of the places we are now having the innovations, such as extending working hours, so that instead of the clinic opening from 8:30 to 5, if it can work a few extra hours up to 8 in the evening, so that the people who are busy with work can come at the end of the day and are able to access. Or open on the weekends. Some of the clinics are opening on the weekends, on Saturday and on Sundays, to make sure that the men, when they are off on the weekends, they're able to reach there. So we are innovating. And these innovations are really showing us some good catch, and we're beginning to reach the men. We want to make sure we reach the men.
As you innovate, Dr. Joshua Musinguzi, there is a sense among members of the public who actually feel like more diseases like COVID-19 are becoming more prominent than HIV. Do you think HIV is taking a backseat?
No, we don't want to take a back seat. Actually, the Honorable Minister and the top management have been telling us now that, yes, COVID has had a 1-year impact on service delivery, but we must get back on the agenda. We must learn how to live within COVID, because we're going to have COVID for quite some time. So I understand that, and I think in the last year it's correct that COVID has been the major focus and priority, but we also made sure that
not only the focus, but in terms of the danger it poses to someone's health. They look at COVID-19 killing you not instantaneously, but 2 weeks is also a short time if you're going to be dying within 2 weeks. But then HIV, you can live for 20 to 30 years. So you have people who feel like, I fear COVID-19 more than I do HIV. So I'll wear a face mask, but I'll not wear a condom, if you know what I mean, Dr. Joshua Musinguzi.
Going back to COVID, I think we've done very well as a country. Uganda has done very well. As you know, Uganda has been one of the countries which has been listed by a number of agencies, including one a publication in the Lancet which showed that Uganda is one of the few countries that have really responded well right from the beginning. And I think it's due to leadership of government, the president, the Minister of Health, and the people that have been involved in this. And we've managed to, in the midst of all these difficulties, been able to really keep the pandemic low. I think we are still at 40,500 cases in Uganda. By the close of yesterday, we have over 350 deaths. Those numbers have really been marvelous. When you compare with how other countries have done. But even as that was happening, the ministry was very clear that we must have continuity of services. We can't say because there is COVID that we're now going to take a back seat and forget about TB, forget about malaria, forget about HIV. So the ministry and the leadership there asked the team to put into place a continuity of services framework. And this has been done, and HIV was part of that package, and we had to modify our approaches. And of course, to minimize those activities which could predispose both our health workers and also the communities to COVID, but also at the same time to be able to provide the services to continue. So for instance, we had to begin things like mouth-to-mouth dispensing, whereby instead of giving drugs for 2 months for patients, especially patients who are stable, many of our patients, over 80% of our patients have been on treatment for some time. They are treatment literate and they are able to manage themselves. So instead of giving them drugs for 2 months, we are able to give them drugs for 6 months so that they don't have to make interfaces that are risky both to them and to the health facilities. We have, for example, have had to also do what we call community drug distribution, where you take the drugs, especially during the early days of the lockdown, where patients couldn't come into the facilities. You could go to the communities and be able to provide the drugs there. And of course, we also had to make sure that we worked with the clients, talking to them, and we decentralized the treatment approaches, because many times there are patients who come all the way from Arua to come to seek treatment here in Mulago.
Indeed.
Yeah.
Okay, Doctor,
somebody coming from Mumbali.
Indeed.
So what we are doing now, we told them you can still get this service
where you are.
Arua, where you are, in the health center too there. You can get the service in Kabari. So all that has helped us, of course, plus also planning well to make sure that we don't have stockouts.
Dr. Joshua Musinguzi, he is actually the Assistant Commissioner AIDS Control Program at the Ministry of Health. We are expounding on the fight against HIV and AIDS. We would also like to know, Dr. Joshua Musinguzi, the correlation, the linkage between non-communicable diseases and HIV and AIDS. According to a survey that was conducted by Mulago Hospital, they actually found out that more HIV people were actually staying alive, but dying because of NCDs. So non-communicable diseases are killing more HIV patients than AIDS itself. Expound on that.
So we have to make sure that we address health in a holistic manner, as I indicated earlier. And we must integrate our services. When the patient comes with HIV or with malaria, we must look at the person. Hypertension, make sure we address all his health needs. We look at malaria, if they have malaria, we look at STI, screen them. But going back to NCDs, which you are raising, that's a very good question that you are raising. We know that NCDs are becoming common, especially with populations people living longer. So anybody who has HIV and has been treated for HIV, has drugs, and as he grows old, he's entitled. He's a candidate for NCDs. So just by the nature of aging, they will be more likely to get NCDs. But also, we know that there are certainly some NCD side effects that can result from treatment. So we are really working on making sure that as part of the integrated package of care, we integrate the management of NCDs and looking at the risk factors, obesity, things like poor nutrition, overnutrition, and address them.
Even some of the antiretroviral treatment itself has been linked to obesity.
Yes, but some of that was in the early to mid 90s, and many of those drugs have now been really weaned out. There was quite good pharmacovigilance, which was looking at some of those issues. We have had also some few cases with some other newer drugs, and we're keeping a close eye, especially with hyperglycemia and diabetes, but really numbers are not very big. But we make sure we treat NCDs, but also...
Do we have what it takes to end this pandemic by 2030? That is the target.
We shall end AIDS by 2030. We are moving in the right direction. All I can say is we need to put our hands together. This is a multi-sectoral issue. I want to make sure that the population takes up the services. The services are there. We have no excuse for not identifying people through testing. We have no excuse for not putting people on treatment because we have the drugs. And we have no excuse for not getting people virally suppressed. And as you know, what we're trying to see is that we continue to bring down the curve, to depress the curve for new infections. We have done very well. Since 2010, we've come down from about 100,000 to now 53,000. at the end of last year in terms of new infections, which is a 50% decline in new infections. We have brought down AIDS-related deaths from a peak of about 70,000 to only 21,000 at the end of last year, which is quite a big decline. Now, what we want to do, which we call epidemic control, what we call epidemic control is when the number of new infections fall below the number of annual AIDS-related deaths.
Dr. Joshua Musinguzi, the Assistant Commissioner, AIDS Control Program from the Health Ministry. Many thanks for having made the time to speak to us. Unfortunately, we've run out of time.
Thanks so much, Romeo, and thanks so much, viewers. I can only call upon the public to make sure they collaborate and take up these services.
Indeed.
The services are there. There is no excuse. Come and utilize them, and we shall end AIDS by 2030 as a country.
Indeed, thank you very much, Dr. Joshua Musinguzi. He is the Assistant Commissioner, AIDS Control Program from the Health Ministry. If you're a sane young man, there's no way you can say that you fear pregnancy more than HIV. The next person in line is going to be Deus Kamunyu.